Well, good afternoon or good Friday evening or whatever time of the day it is. Welcome to SADS Facebook Live, episode number 37. Oh my goodness. So many of you, I'm going to see some names coming on live shortly, and we'll recognize some familiar names and faces like Felicia, who we interviewed just a couple weeks ago, and I got to see her again recently. But it's great to be with you and spend the next 40 minutes together. I'm really excited about our program today. I think you're going to learn a lot and learn the excitement of the genetic revolution of genomic precision medicine as it relates to our world, of our families with genetic heart diseases, genetic heart channel diseases, the channelopathies, and so forth, with our discussion together with Chief Medical Officer of Invitae, Dr. Robert Nussbaum. But before I bring Bob on, yes, the COVID pandemic's still with us, isn't it? Let me show you something that I don't like, you don't like. See that? Yeah, this is yesterday set the record for the United States for the most cases in one day, 122,000 cases in one day. The United States, since we were last together last Friday, we added about 6,000 deaths in the United States. So come on, everybody, get the message out. Put on your mask. This is Mayo Clinic's mask now. Last week I sported the SADS Foundation mask, but this is from us at Mayo Clinic. Put yours on. I wear mine. Wash your hands. I do that. You do that. Stay apart 6 feet. These things that are not rocket science actually work, but we've gotten really, really, really sloppy, and now we're paying the piper for this in the United States and throughout the world. Thankfully, we know how to treat SARS-CoV-2. The death rate is way down, but the number of cases are exploding and starting to overwhelm the healthcare systems throughout the United States. And if it overwhelms the system, we're going to be very good at treating even those that are treatable. So come on, everybody, let's do it. We can do this. Well, SADS Facebook Live number 37. Today, I have the pleasure of introducing you all to Dr. Robert Nussbaum, and he's going to be joining us shortly. Right now, in fact, I imagine, from the magic of Aaron. Look at that. Bob,
hello, everybody.
SADS Facebook Live.
Hi, Mike. Good to see you, and hello, everybody.
Great to have you with us. And on behalf of Alice Laura, the CEO of the SADS Foundation, welcome everybody out there to the program. Bob, welcome to the program. And we're going to talk about genetic testing today. We're going to talk about Invitae and the place of the company Invitae in the world of genetic testing for our family's diseases, long QT, Brugada, CPVT. We may even take some of your questions as they come on if they relate to genetic testing. So pitch them my way. I'll glance off to the side every once in a while and see if something is going to be relevant for our conversation with Dr. Robert Nussbaum. But before we talk about genetics and Invitae and genetic testing, Bob, let's talk about you. So give a little thumbnail sketch of your professional career and your journey from medicine and academia to science to industry and to your current role the last several years now as Chief Medical Officer of one of the largest genetic testing companies in the world, Invitae.
Well, thanks, Mike. I had never really anticipated taking this job at Invitae. I'd been in academia for 40 years, seeing patients in genetics. I'm not a cardiologist. I'm trained in internal medicine and then trained in clinical genetics and clinical molecular genetics, which is the specialty that really focuses on laboratory testing and genetic testing. And before joining Invitae in 2015, I was at the University of California, San Francisco, where I helped start a new program in cardiovascular genetics with colleagues like Mel Scheinman, one of the pioneers in electrophysiology, and many of the other people there, because of the growth of our knowledge about the genetic contributions to arrhythmias. And what happened is that as the Genome Project developed, and our knowledge about the genetic underpinning for these diseases increased, the industry and our ability to offer testing, needed testing to people, did not keep up. I found myself getting more and more and more frustrated
Hmm.
by an inability to provide much needed genetic testing to people and their family members, their relatives. And we're going to talk much more about that a little bit later. And I know that Mike, in some comments that we had before the session, shares with me some of this frustration with trying to get genetic testing available, and that what happened was really three things have revolutionized our ability to provide adequate genetic testing. Number one, in 2013, the U.S. Supreme Court, by a vote of 9-0, ruled that you could not patent a gene to use for testing purposes. You can patent it for other sorts of things, if you're going to make a medicine out of it, whatever. But if you're going to do genetic testing, you cannot patent genes. This removed a lot of barriers to being able to get testing going. So that was number one. Number two was the development of public databases that allow people like me and people like Mike to share information about patients, not in an identified way, de-identified way, but allows us to share information so that if you have CPVT due to a particular change in a gene, and there are 6 other people who may have been tested in other laboratories who also have CPVT with exactly the same variant, we now know that. Before these databases, this information was kind of squirreled away and wasn't being shared, to the detriment of clinical care.
Right.
So that's really the second big change. And the third is the technology involved in DNA sequencing has just driven the cost of it down very, very far. So when I joined Invitae in 2015, it was because their mission coincided so much with what I wanted to do. One, drive the price of testing down so far that people will stop arguing about it. Number two, share your data. Make sure that in other parts of medicine, just imagine if radiologists in the X-ray departments did not share their images with each other so that the appearance of a particular change in the lung due to a particular infection, let's say, 10 other people might have the same picture with the same condition, and yet the radiologist wouldn't learn from each other. That's impossible. I mean, you would never set a system up like that. Yet that is how genetic testing was until the advent of databases. And Invitae is a huge supporter of the big public database called ClinVar, which has 1.3 million variants in it, of which 400,000 came from Invitae alone.
Wow.
So
and now, Bob, so you became chief medical officer in Invitae in 2015?
Yes.
And I want to bring us from like 2014, 2015 to the present with the role Invitae has had in genetic testing. Full disclosure, I've had a relationship with Invitae. I've served on their scientific advisory board. I receive no royalties and have no equity in Invitae. But it is a company that I'm very familiar with. I try to do my best to give my perspective as a so-called KOL. We've heard those 3 letters recently. But before we do, maybe can I stroll down memory lane a little bit?
Sure.
With what the scene and the landscape look like for our Facebook Live members? Because you mentioned a key change, Human Genome Project, 2003. That was a dramatic inflection point in genomic history, wasn't it?
Yes. I mean, it provided absolutely essential information to allow us to then do the next step, which is to find out which genes contribute to what disorders.
Right.
We knew very little. For example, ARVC, arrhythmogenic right ventricular cardiomyopathy, has become one of the conditions that the SADS Foundation is involved with. We basically had no idea of what the genes were, all the genes were. And once we had the Human Genome Project, we're able to use that essentially as a roadmap to be able to trace what are the genes which, when altered, produce ARVC? What are the genes which, when altered, produce the different arrhythmias? So
yeah.
Absolutely
let's scroll
essential.
back. We can even scroll back the clock, can't we, before the new millennium to really, I kind of start the history of genomic cardiology, 1989, everyone. That's when Dr. Christine Seidman at Harvard, discovered the first hypertrophic cardiomyopathy gene, MYH7, opened up the whole field of the inherited cardiomyopathies. Then 1995, Dr. Mark Keating's research team. I'm just wrapping up my final year of medical school and graduate school in 1995 when he publishes in Cell back-to-back articles in the same issue, LQT2 gene, LQT3 gene, and opened up the channelopathies. The next year, he published the LQT1 gene,
Right.
and we had the trifecta, Mark Keating's team, of the three major genes for long QT that have been the three major genes and will always be the three major genes. You know, it's interesting on that starting point, Bob. I've said for many, many years now that I think the Nobel Prize Committee has missed it, because I personally think that Dr. Christine Seidman and Dr. Mark Keating should be receiving the Nobel Prize for that breakthrough, because that was another complete paradigm shift in the entire world of genetic cardiology. And I think their discoveries should have been, maybe they still will, but should have been recognized with the Nobel Prize. I think that's how impactful it was.
Well, I'm happy to nominate them.
Yeah.
I mean, but part of the context of what you're talking about, Mike, is the amount of work that went into finding those genes was enormous.
Yeah.
It could have been short-circuited tremendously if the Human Genome Project had been available at that time. So that's part of what made them such pioneers. They went out into uncharted territory to find those genes.
Right. So that we find the genes, and then it's interesting, everyone. We went into the decade from 1995 to almost 2005 as to what I call the black hole, the time and place where samples went and nothing came back. And that's because we had Mark Keating and his team trying to find the next long QT gene and the next long QT gene, and nobody was really doing the known genes. And that's when we stepped in at Mayo Clinic, Bob, 1999. I wrapped up my fellowship. We offered pseudo clinical genetic testing. There was no clinical genetic test. So our research program under Winland Smith Rice Sudden Death Genomics Laboratory, we stepped in and saw a gap and said, well, we'll do our best. We will take samples and we'll look for the known genes, and we'll let Mark Keating find the next new one. And so we assembled hundreds and hundreds of samples and did our best. And in fact, from that collection, our research team ended up discovering almost all of the minor long QT susceptibility genes. But that wasn't our primary mission. Our primary mission was actually to step in the gap and meet a need and take care of my patients, where I wanted to know, are they long QT1 or LQT2 and so forth. And then really, like everything, that black hole was ended because we had maturation of genetic testing. Okay. So the first genetic test for long QT commercially, as some of you may remember, is the Familion test circa 2003. But that was a new problem, wasn't it? So everybody wanted genetic testing. Now it's there, and we have a new problem. Clinically available, denied, available, denied. Yes. Price point back then, $5,400
right.
to run the small panel of 5 or 6 LQT genes. Right. So very frustrating. And I think that's what you were speaking to, weren't you, with
yes.
your experience at UCSF with Mel Scheinman? We know it, we want it, we need it, but we're not getting it.
That's clearly a problem. And of course, Mike, as you know from the work you did when you started out at Mayo, is even once the genes were found, it opened up a whole new problem. And it's something that you and I talked about earlier. And that is, you may find changes in a gene, but you don't know that those changes actually cause disease.
Right.
And in genetic testing, as opposed to having yes, abnormal, no, normal, there's in fact 3 possible outcomes. Yes, disease causing, no, not associated with disease. And then in the middle is a change that we don't know how to interpret.
Right.
And we are still struggling with that in the clinical world. things are getting better. The more information we have, the better a job we can do. So in the early days, when Mike was first starting out and doing this, you had a lot of changes that you found, and there was just no way to interpret what they meant. And of course, part of what was so good about what you were doing was that you had careful evaluation of the patients, the clinical so-called phenotyping.
Yeah.
You knew what they were doing. So what Invitae has done is to say, look, it's ridiculous to charge $5,500 for a couple of genes. With all the current technology, we can offer very large panels. I mean, we're talking about dozens and dozens and dozens of both cardiomyopathy and arrhythmia genes for $250.
Yeah, that's been the incredible. So that's been the dramatic log fold reduction, 5,500 less to do the whole enchilada, which then there was two other big breakthroughs, right? So one was the price drop.
Right.
The other was that denied change when insurance companies started to recognize these genetic tests as bona fide clinical tests with real clinical value, diagnostic, prognostic, therapeutic. And they started to say genetic testing for these diseases are no longer investigational research tests.
Right.
We still work with that. I know you at Invitae still work to make the argument to the insurance companies why it's in the best interest of their members of their insurance plan to get to have access to genetic testing.
Right. It's a cooperative effort between the clinicians who are taking care of the patients and the genetic testing companies. Because what we find is it's the physicians who say, you know what, if I knew that this was a long QT1 versus a long QT2 versus a long QT3, I might treat this patient differently. It's going to make a difference to the outcome. Furthermore, if I know that this patient has ARVC and I know what the gene is and what the change is, there are family members who also need to know in order for their health to be monitored and to be taken care of. And equally important, as a geneticist, I can't tell you how often the situation has been that someone has had a condition like this. And the first question out of their mouth is not, hey, doc, what does this mean for me? The first question out of their mouth is, doc, what does this mean for my kids?
Right.
And to be able to test the children and to be able to say, this child did not inherit the problem that you're having, enormous relief. It just makes a great difference. On the other hand, you say this child did inherit it. Fine. Now we know in advance. We don't have to worry about what happened to your cousin who unknowingly suffered a fatal event.
Powerful medicine. I mean, so powerful that this whole month is National Family Health History Month in the United States. And I think the point you were just making, Bob, is the when you have found the disease causative variant, its ability to be absolutely clarifying for who in the family does and does not have it, who did or did not inherit it. We dismiss those who did not. We treat effectively those who did, and tragedies don't happen when we know it's there.
Yeah, exactly. And so we believe so strongly in this that at Invitae, our system is, if you get a test from us and it's either paid for by insurance or paid for by patient, whatever way it gets paid for, if we find a positive result, we have folded into the cost of that test the cost of testing all the relatives of that individual without any additional charge. It's already folded in. So we are trying to encourage family members to talk to each other, find out about that great uncle who had such and such, or that cousin who had whatever, and then encourage people to seek the testing that will clarify, are they at risk or are they not? And we try to make that as easy as possible.
Yeah, and let me talk how you've done that, because I think really as a user of genetic testing a lot, and somebody who's been there from day zero for the world of genetic cardiology, I think Invitae has been unbelievably innovative and transformative in just the whole approach. So we talked about 2003, we now have clinical genetic testing, but it's at a price point that's out of reach. And 75% of my patients are getting 75% of the tests denied. To now, it's in reach to almost everyone. And we have a increasingly positive reimbursement landscape where it's being covered, but increasingly we don't even need to know that because of the model that you guys have really innovated to then now a new issue that's emerged where we have it increasingly available, increasingly being used, and unfortunately potentially being used by clueless users. Mm-hmm. The ordering physicians who don't know how to speak the language of genetic medicine. And so you've done some other innovative things by embedding genetic counselors as critical components of your company and to help come alongside cardiologists who aren't a genetic cardiologist like myself, for example. But let's enter in 2014 now. Yep. 6 years ago, Invitae comes on the scene. Familion eventually dies. That product went from one company to another company to another company. I think the original product from Genesance Pharmaceuticals, long extinct now, but they launched Familion. They deserve a lot of credit for creating the birth of clinical genetic testing for long QT. Mm-hmm. But you all at Invitae have totally changed the landscape. So how did that happen? What is Invitae's mission, its model, and how it kind of took the way it was being done and saying, no, there's a better way of doing genetic testing. We're going to create a whole new paradigm. Give us a little insight into how that happened.
Well, one of the points that you made, Mike, is really important one, and that is that not all providers are equally sophisticated in the use of genetics. So one of the things we wanted to do, our mission is to make the genetic testing process easier and seamless and effective. So one way to do that is we have a group of genetic counselors. A number of them have been trained, very well trained in cardiovascular genetics. We also have another group of genetic counselors that are part of what we call our clinical consult service. So a physician can call us, no additional charge of any kind, can call us and say, I'm thinking about ordering a test on a patient, or I've ordered a test on a patient, I'm having a little trouble understanding what it means. Can you explain it to me? So that's the clinical consult group, right. And we offer that freely. We also offer, at no additional charge, genetic counseling, so that for the patients, they can talk to us about a test. What did the test mean? What do the results mean? We can hook them up with experts in electrophysiology and in cardiology in their local area to make sure that they get appropriate care and appropriate follow-up, and we can help them with the outreach to their other family members. We have letters that are available. We can give people and say, you are not genetic counselors. It's not your job to explain all this stuff to your relatives. Here's a letter that explains what happened and why we think it's important that your relative should seek genetic testing. So what we're trying to do is, it's not just a matter of driving down the cost. Right. We're trying to make the whole process seamless and support patients and providers who need that kind of support. Not everybody who orders a genetic test is a Mike Ackerman. Those are the facts.
Yeah, and we probably don't want too many of them. I wonder, if you could, you mentioned earlier the uniqueness of genetic testing, compared to, yes, there's a tumor, no, there's not, nothing in between, which even there in their world, pathology is not always yes and no. But in our world, we have yes, no, maybe. Would you share with the audience a little bit about your all strategy for wrestling with and chewing on the maybes? They get called, everybody, yes. You told me, variants of uncertain significance, and some of you have been vexed with a VUS, wondering what does it mean or doesn't it mean. Yours truly has published a paper called Genetic Purgatory, because
Yeah.
that's the imagery that I wanted to convey
Yeah.
now 5 years ago, about how stuck we might be and how sometimes we can get unstuck really quickly, and how sometimes we're stuck deep in doo-doo land where we just don't know enough. But you guys have a systematic strategy of doing your level best in current knowledge and even future knowledge to adjudicate variants to the best of your ability. You guys have dubbed it Sherlock, I think, from
Yeah.
Sherlock Holmes and the detective work. But what does that look like a little bit? Because I'm sure people are wondering, do you get stamped a VUS and then you guys are done and you never look at it again?
That's a great question.
What's the drill?
So the drill is that we have a system. It's called Sherlock, and it's a quantitative point system that pulls in all the current information available from the published literature, from our own databases, from ClinVar, wherever, about that variant. What do we know currently about that variant? And then we ask that question again in a few months. So we ask it again in a year, so that if new information comes along that's going to alter what we think about it, it will result in an amended report. We'll send out another report and say, we called it a VUS 2 years ago, but now we know that it's benign, or now we know that it's disease causing. And we just recently instituted a system. It's really it's a very complicated system. I really can't explain it in too much detail, but let me just say that it uses vast amounts of information that currently was not being used by laboratories to do variant interpretation. Very complicated three-dimensional structures of proteins and other sorts of information. And we have figured out a way to bring it all together and apply it to variant interpretation. Now, I mentioned before about ClinVar. It's called Sherlock from Sherlock Holmes, but there's this wonderful quote from Sherlock Holmes from the story Silver Blaze, where Sherlock Holmes says, "There's nothing that clarifies your thinking about a problem as much as having to explain it to somebody else." And in ClinVar, we not only put in what we think a variant is, a benign or VUS or pathogenic, we give the reasons. Why are we calling it that?
Yeah.
And that is critical. Not all labs do that. We do, because we want people to be able to look at that and say, well, we have some other information that we could add to that, or that's why they're calling it that. It's not just what are we calling it, but why. So that's what we do. VUSs are still a major problem. If you'll allow me, it's a serious issue involving health disparities, because a lot of the information that's been generated in genetics has come from only one area of the globe.
Yeah.
That is Europe.
Right.
And we know from a lot of research that's been done that the amount of variation in the sequence of genes, that amount of variation is tremendous in other parts of the world that we don't see in Europe at all.
Right.
So that when I'm faced, and Mike, I'm sure you've had this experience, when you're faced with a patient whose ancestry does not map to Europe, there are variants there that really no one has ever seen before.
Right. Yeah, fun little trivia fact. Our program was the first in 2003 when everybody was rah-rahing the Human Genome Project as the greatest thing ever. And I agree, it is profound. We started to put out the warning and saying, be careful. Interpretation is going to be challenging, especially in those who don't look like me, because we showed that the genetic noise in the long QT genes, for example, was 3 times greater in African Americans and Asians and Hispanics. And it feels like it's taking 10 years for the rest of the world to catch up and say, there's a lot of genetic noise that we have to try to Sherlock our way through and get smarter about. Give a sense of how big of a task this is. You mentioned the scalability of Invitae. You arrived 2015-ish as CMO. How many genetic cardiology tests did you guys run when you were there compared to say last year, just so SADS Facebook Live Land gets a feeling of how huge the Invitae cardiology and non-cardiology genetic operation is.
Well, when I first came, it was really a matter of a few hundred. In last year, we did our total amount of testing. That's all clinical areas, not just cardiology. Our total was pretty close to 500,000. And
Wow.
of that, about, I'd say 25% or so was cardiology. I mean, the current situation is that oncology, the cancer world, is still a very dominant part of what genetic testing is about. But about 25% of 500,000 would be a kind of an estimate of about where we are. And
that's a big number.
It's a big number. It's a
right.
big
And
number.
oncology was sort of 95-5 for Invitae, but now 75-25.
Yep.
So, and of the amended reports, would you say, how frequently do you find yourselves sending an amended report in the cardiology space? I think it's got to be encouraged for our listeners to know that it's not a one and done report, so
Right.
be it, but there's a vetting and a review process that you all do. And how often does that result in having to give an update to the ordering physician and the family that, we need to call it a little bit differently than what we originally first did?
Yeah. I can't give you the specifics of cardiology versus other areas, but I can give you the total.
Yeah.
So, for example, with the introduction of this new system of interpreting variants that's using a lot of this complicated data, in the space of 4 months, we issued over 15,000 amended reports.
Wow.
Simply from introducing this, I'm using the word simply, but because of the introduction of this
Right.
new approach. And then this new approach is being used now prospectively. It's not that we just did it and then we're all done. This is continuing to be applied to our variant interpretation. But I don't want people to come away with the idea that VUSs are going to be extinct tomorrow.
Right.
They are still a major problem, particularly for the global community. And we have to find better ways of figuring it out.
Achilles heel of the genetic test, and it is. In our last few minutes, Bob, I want you to share a little bit about a recent test that you've offered that we at Mayo Clinic in our Winland Smith Rice Genetic Heart Rhythm Clinic use more and more, and that's your Invitae Detect panel.
Yeah.
I know we have the LongQT panel, those genes. We have I think it's Brugada, those genes. Yeah. But you have what we have affectionately dubbed at Mayo the monster panel. Right. Of 150 genes is the current size of Invitae Detect. Essentially, every known gene that has been implicated in sudden cardiac death, predisposing heart conditions, heart muscle conditions, heart rhythm conditions, and so forth. But you use that as a way and a strategy to basically make sure that this test is now accessible to basically anyone, anywhere. How did that come about? And what is the background behind Invitae Detect?
Sure. Thanks, Mike. I think it's a fascinating story. It actually starts outside of the cardiology world. It starts in the world of pediatric neurology, and in particular, epilepsy. About 4 years ago, a biopharma company came to us and said, we have a new treatment for what was previously an incurable degenerative disease of children. We can now treat it. The problem is the patients aren't being diagnosed with it. Or they're going undiagnosed for a year or two before the diagnosis is made. And at that point, a lot of damage has occurred that is irreversible. What can you do to help us identify these children early? So what we said to them was, look, as far as we know, these children constitute about 1 to 2%, that's all, of all the children who present with a seizure between age 3 and 4. So why don't we do the following? Let's cover the cost of testing any child who presents between ages 3 and 4 with a seizure, and some small fraction of them will turn out to be ones who could benefit from your treatment. We would then go to the provider, not the patient. I want to stress this. We do not give out patient information, but we would go to the provider and say, you ordered this test. It turns out your patient has a condition that is treatable by this biopharma product. Would you like to talk to them about it? And the provider would say, well, of course, it's treatable. It's something I'd like to do.
Right.
That has now expanded. So now we're doing it for all children aged 0 to 8. There's, I think, as many as 10 or maybe more of biopharma companies, pharmaceutical companies, who have either clinical trials or therapies for different forms of epilepsy. So they're all joining together. So then what happened in Invitae is we said, hey, look, why should we have to wait for a biopharma company to come to us? We know that it's very important that patients get diagnosed with either heart muscle disease or an arrhythmia. Why don't we set up a system where we will offer sponsored testing? It will not cost insurance companies anything. It won't cost the patients anything. We're going to cast a very wide net, which is why it's a monster panel.
Yeah.
Cast a very wide net and say, look, we will offer this. And the only thing we ask in return is that if we find a patient who has a particular type of mutation and some biopharma partner comes along later and says, hey, we're interested in all your CPVT patients, we would say, fine, we will connect you to the providers who ordered that test. And it's up to them then to say whether they want to connect you guys or not.
Right.
So it's kind of a build it and they will come idea, similar to the film about baseball. So that's what the sponsored testing detect program is about. And it's catching on all over. I mean, lots of.
I think it's one of those, like you said, the Field of Dreams movie, great movie.
Yeah.
I guess that formula, and again, part of the uniqueness and innovation of Invitae is, I call that a win-win-win.
Yep.
And most importantly, my patients win.
Right.
Because my patient who I need to get that genetic test now doesn't have to wonder, if my insurance isn't covering it well enough, do I have to not get it because I just can't financially do that right now? And yet I get the information. I now can take better care of my patient, because I know the answer. I know at least the current state of the answer. And I think your point of when the families do Invitae Detect and they sign their name giving permission, they are not signing their name giving permission for their identity to ever be revealed.
Right.
Just their raw genetic data that won't get traced back to them unless they and their healthcare team would choose to do so.
Exactly. They have to specifically agree to it. Exactly right. We don't sell patients' data. So
I think that there's been such, we're talking Invitae just the last 5 years.
Yep.
Let's give us a sneak peek into what you envision the next 5 years are going to look like for genetic testing for my patients.
Well, I think the first thing that's going to happen is that we're going to know much more, and we're going to be offering even larger, essentially whole genome analyses, that when someone needs a genetic test done, we'll look at all of their genes, because we still don't know all the genetic information that contributes to particular disorders. And in fact, we now know from cardiomyopathy cases, at least, that some fraction of patients, about 1 in 25 or so, actually have 2 alterations, which are interacting. So that kind of interaction business. So that's the first thing. The second big change I think we're going to see is that there's going to be even more sensitive testing for genetic changes that may not even be in the DNA. They may be in what's called epigenetic changes, things that affect the way a gene behaves, not because the gene's been changed, but because of the way it's packaged inside cells. And we're going to start to learn more about that as well. I think genetic testing is going to become much more available to people who are simply want to know, am I at risk for something? not because of a family history, although family history is extremely important, but not because of family history, not because of their own history, but it's going to be more of a population-based screen for risk factors. So there's a lot happening. I mean, I can't believe what's happened in the last 5 years, and I hope I'm around for the next 5.
Well, I hope so too. It's been a great. Thanks for giving your time for us on SADS Facebook
my
Live,
pleasure.
Dr. Nussbaum, and I'd love it if you could join us again.
Sure.
But before I let you go, we did say we would have some questions on the sidebar. I did say that it is National Family Health History Month. So, Sophie, you win the question of the day. So, Sophie, and I think we'll end with this. Thanks, Sophie. Bob, she says this. She's been diagnosed with long QT from an electrocardiogram after her brother and mother both tested positive for LQT2 mutation.
Okay.
Is it necessary for her to do the genetic testing to confirm that she also has LQT2? I'm under the supervision of the cardiologist and take beta blockers. Now, Dr. Nussbaum's amazing. He's in internal medicine. He is a geneticist, but he's not a cardiologist. You heard him say that.
Right.
I'll start with this one, and then you see if I got it right.
Go ahead, Mike.
So, Sophie, assuming you are under the care of a good cardiologist who knows how to stare at the ECG, the EKG, who thinks he or she is absolutely sure that the ECG looks like LQT2, even if that cardiologist, he or she, is really confident, get the genetic test. I've seen so many overdiagnoses or presumed diagnoses based upon funny T waves when it's the long QT is in the family, and then they test negative for the family mutation. And those funny T waves just turned out to be funny and really an overdiagnosis or a presumed diagnosis, because her pretest probability without doing anything is already 50-50 chance. Right. So I don't even need to know what the ECG looks like to flip a coin. So he or she is probably right. Your EKG is probably indicating that you did get the long QT2 mutation, but please do National Family Health History Month and seal the deal and prove that you did in fact inherit the family LQT2 mutation. Did I do okay with that, Bob?
I couldn't agree more. Why guess? I mean, we know exactly. It can be a clear-cut yes or no. There's no variant of uncertain significance issue here. We already know what the disease-causing changes in your relatives. Do you have it or do you not? And Mike's point about so-called false positives, ECGs that look like they might be long QT but aren't, is a problem. And why should you be saddled with a diagnosis that you don't deserve? Right. Answer the question.
Yeah, the electrocardiograms, we've been very honest, haven't we, over the years, that the genetic test is tricky. Yes, no, maybe. But we haven't perhaps been as transparent with the interpreting the electrocardiogram, which has been around since, Eindhoven, over 100 years. And sometimes the ECG is obvious, easy, and totally interpreted incorrectly.
And there are medications that in some people will prolong QT. It doesn't mean you have the genetic form. So get the test. Simple enough to do.
Well, I look forward to bringing you back to update us with your vision at Invitae and progress with the VUS issue and learning more about that, and have you sharing it with, maybe it'll be SADS Facebook Live number 60. We'll keep you posted.
Good. Thanks, Mike. A real pleasure, everybody. Stay safe. And Mike's advice about what to do about coronavirus, we should all take that to heart.
Bob, thanks so much. And all of you out there in SADS Facebook Live land, as you're getting ready for your weekend, join us tomorrow. If you don't know about it, we are having, the virtual conference for the SADS Foundation. We have over 300, and many of our, probably you, signed up from, I think, over 30 countries. It's going to be awesome tomorrow. We have Dr. Prince Kanackrell from Vanderbilt University speaking. We'll have Dr. Susan Etheridge from Salt Lake City sharing her thoughts with us on therapies. both current and future from both of them. I'll be joining you all to take your questions for a full hour, I think, in the What Say You and What Ask You fireside chat. I can't wait. Now remember, tomorrow is probably going to be one of our nicest weekends that we've ever had in November for Rochester, Minnesota. Sunny and 70. We never get that. But I'm going to be indoors, yes, with you all. So I hope you'll spread the word. You can still sign up. You can still share it with your fellow SADS family friends. It's going to be a great virtual conference. And then I share this picture for Brianna. Oh, yep. This is me from last Saturday, a day with my son in Montana. Just an FYI, horseback riding is not a great idea when you're recovering from a herniated disc in your neck. Set me back a lot, but a day with my son is worth all the discomfort that I'm feeling at the present. But anyway, SADS Facebook Live number 37 is in the books. Until next Friday, stay well, stay safe, stay masked, and stay corona-free for as long as you can. Be well, everyone.